So welcome everybody. It's really my pleasure to moderate this panel discussion from some distinguished individuals who'll be talking about Alzheimer's disease. Of course, this is the Alzheimer's Awareness Month, which obviously is important both from scientific side, but also, for people who are suffering from this problem and the family who have to deal with their individual loved ones involved with this debilitating disease. So let me just introduce myself. So I'm Dr. Lawrence Stanton. I'm the Center Director at QBRI's Neurological Disorders Research Center. I've been in Qatar for a couple of years now. We'll give you a little bit more of an overview of QBRI and our interest in neurological disorders and other research from Dr. Nasser, who is our Center Director, our Research Director. So here you just see a little picture of me and my interests. So we're going to kick off this program here. So just a couple of housekeeping items before I introduce speakers. We want this to be interactive. We have 3 presenters, and what we're going to do is hold off on the question and answers till the end of the presentation. So let the 3 presenters present their talks, and then we'll do a Q&A. And the best way for that Q&A to work seamlessly is for you, whether you're on a web interface or on your phone interface, to just record your questions in the under the Q&A tab. And so it depends on what your interface is, but you find the Q&A tab, write in your questions, and then I'll pull from those questions as they accumulate. At the end of the talk, I'll pose them to the panel to stimulate discussion. So we look forward to your informed queries to the distinguished speakers. What's the next slide, Omar? Okay, so I guess without further ado, now that we have the ground rules, so as I mentioned, we'll have 3 presenters. The first one will be a 5-minute presentation from Dr. Nasser Zawiya. Dr. Nasser is the Research Director at QBRI. So welcome, Dr. Nasser. So if you can flip on your video, there's your video, and we should be able to share with you the screen option. So you can pass that over, Omar.
So I don't need that. I will be just talking, so I don't need to. I will not be sharing any slides, so you can just keep it the way it is.
Okay.
Thank you, Dr. Stanton, for that introduction. My name is again Nasser Zawiya. I'm a new research director at QBRI. I'm also a member of the Neurological Disorders Center, which Dr. Stanton, heads. It's my pleasure to be with you today. I've been working on Alzheimer's disease for over 20 years, but mainly using animal models and trying to understand, the pathogenesis of Alzheimer's disease. Just a little bit about some, questions we normally grapple with, and during this Alzheimer's month, Awareness Month, and Dementia and Alzheimer's month, I'd like to just, reiterate for you, 3 questions that we always have been struggling with, even though we've made many advances, particularly in the last 20 years with Alzheimer's disease. But the issues that are still persist and challenge us is, one has to do with when does the disease, begin? And the second question has to do with what is really what causes the disease, and what is really exactly are we talking about? And the third question is why. I think trying to answer the when, what, and why are kind of what has been, occurring for quite a while. And my own personal research before joining QBRI, I've been, looking at the when by using animal models, and looking at maybe the why as well by, modeling environmental exposures. And my, seminal work has to do with the, providing some evidence that there is a developmental basis for Alzheimer's disease. Because we are not sure, does Alzheimer's disease begin when you're old? Does it begin, in your middle age? Does it begin early in life. And in this case, I'm speaking of sporadic forms of Alzheimer's disease, where 95% of the patients, it's very random and occurs, in older age, 65, or later. So using animal models, we showed, that at least an environmental agent such as lead, early life exposure seems to promote at the end of life, overexpression of key hallmark, genes and proteins involved with Alzheimer's disease, APP, tau, amyloid, pathology, burden, and also impacting memory and learning due to an experience early in life. So with our animal models, at least we can argue that there are earlier beginnings for Alzheimer's disease. Whether our model holds for humans, is it as early as very early in life, when, in life? But it seems, we can look at Alzheimer's disease and think of it as a latent disease that manifests itself in old age, but may have earlier beginnings. The what, triggers that when something is really sporadic and random like this, and does not have, in the sporadic form, obviously, there are two types of Alzheimer's disease, early onset and late onset Alzheimer's disease. With late onset, Alzheimer's disease load, the what may be some environmental trigger. And years of work, coming from my group and my lab have showed that environmental exposure through epigenetic pathways and reprogramming of the brain through early life exposure may be, what may be leading to some of the pathogenesis of Alzheimer's disease. The why, is another question that still we are all really struggling with. And why does it happen, in this population or not? For example, the key hallmark, features of Alzheimer's disease, the plaques and the tangles that we pathologically can see and image, those are also present, in healthy aging individuals. So when we're trying to develop, diagnostic markers, such as our work here with biomarkers at QBRI, we have to always be cognizant of the fact that these biomarkers are present both in healthy aging individuals as well as in diseased individuals. The difference is maybe in the burden and the amount and the intensity, of plaques and tangles when it comes, to those with late onset Alzheimer's disease. So those are questions. Then why are certain populations, why are certain individuals have a acceleration of some of these events and others do not? So we still, do not, understand that. Why certain populations and, are affected more than others? Does, diet and other things and other protective things delay in some cases? We also do not understand why there's a specific pathological pathway where, the degeneration begins, in the frontal cortex and then has a specific, pattern, and it's not really very random in how it goes back. So I don't want to take too much of your time. I think my colleagues who are presenting have formal presentations, but as a new person coming to Qatar here for a few months and looking forward to really working on developing my research, I would like, to give, the floor for the others. My work here at Qatar, at the NDRC and QBRI will focus on drug development for neurodegenerative diseases. I do have, I have a orphan drug designation from the FDA for one of the repurposed drugs that I've worked on, and currently working on advancing all this, animal work into clinical trials. So without any further ado, I'd like to yield the floor to my colleagues, and I'm happy to answer any questions that you might have later on. Thank you.
Thank you so much, Dr. Nasser. It's great to have you here with the panel, and it's also, of course, great to have you as a colleague at Qatar Biomedical Research Institute. So I look forward to our future research together. So as I mentioned, we'll do the Q&A at the end. We can address comments and questions to all the panelists. So it's now my distinct pleasure to introduce our next speaker, which is Dr. Shafi Khan. So our two speakers following now are both from Hamad Medical Corporation. So we're really pleased to have these clinical specialists in Alzheimer's telling us their views on this important topic. So Dr. Shafi is a senior consultant geriatrician at and assistant chairperson, Department of Geriatrics and Long-Term Care, Geriatric Fellowship Program Director at the Hamad Medical Corporation, which is, for those outside of the country, is the major health center here in Qatar. So Dr. Khan joined HMC in 2016 after having extensive postgraduate training in geriatric medicine, internal medicine, and stroke in the UK. Dr. Khan was appointed as the program director for the fellowship program in 2017, has led that program towards accreditation. He's a successful graduate education program. He's received continued accreditation with combined support of chairperson, faculty, and fellows. He has an active role in teaching medical students and has been appointed as assistant professor at the Weill Cornell Medical School here in Qatar. So he was appointed as the assistant chairperson of the Department of Geriatrics and Long-Term Care in 2018 to support the leadership and service development initiatives of the department. In December of 2020, he oversaw the integration of the mobile health service into the home health care service under the guidance of Dr. Hanadi Al-Hamad and Dr. Asa Al-Sulati. So Dr. Khan has a wide variety of clinical and academic interests, including acute geriatrics, long-term care, memory services, teaching, research, and quality improvement. So you can see from his background that he's quite a good person to tell us a little bit about his understanding of Alzheimer's disease and a perfect person to be on our panel. So thank you for joining us and taking the time, Dr. Shafi, and we look forward to hearing your presentation, and I'll turn it over to you.
Thank you, Dr. Lawrence, for an amazing introduction. Thank you, Dr. Nasser. It's great to meet you today. I really enjoyed your approach, the way how you have approached regarding when, what, why in your research. So I'm just going to try to answer some of the basics of dementia, a little bit about Alzheimer's, and I'll finish off with what we can do at the end as community. So I have no conflict of interest. I hope you can see my slides. Today's outline.
We can see everything fine, Dr. Khan. Everything looks good.
Thank you so much, Dr. Lawrence. So the outline of my talk, why are we here today? Just a little bit basics about brain, understanding definition of dementia, what are the symptoms, what are the different types, including Alzheimer's, and then I'll touch base on the risk factors and briefly on diagnosis and management, and collectively as community what we can do. So why are we here today? The reason why we're here today is because there are more than 50 million people with dementia at present, as we speak right now, who have been diagnosed. And as we progress into 2050, the projection is about 139 million people will be diagnosed with dementia. Every new case is diagnosed at every 3 seconds. 75% who are undiagnosed because either due to lack of awareness or stigma attached to the disease, people tend to hide from the general mainstream. 80% are in the community are concerned about dementia in the community. 35% of the carers, as I mentioned earlier, hide the diagnosis, and more than 60% of the carers suffer with some form of psychological or carer strain. It's a huge economical burden on healthcare systems with up to 1.3 trillion US dollars worldwide. Just a few statistics in Qatar. There are about 4,400 suspected to have dementia when we started our journey in 2017. And it is expected to go as high as 41,000 by 2050. Currently, there are more than 39,000 older adults with an age of 65 or above. The expectations in the Middle East by 2050 is there will be a 125% increase in cases of Alzheimer's. Hence, as per the World Alzheimer's Month, which is celebrated on the 21st of September, to raise the awareness and reduce stigma, we have been proactively taking part in this for the last few years under the leadership of Dr. Hanadi Al-Hamad. It's a great privilege to be working with so much intensity with Dr. Hanadi and clinicians, old age psychiatric colleagues such as Dr. Mani and Dr. Pravija, who are based in our department. Just a little bit about the brain, just a few basics so that you know what I'm trying to convey the message across eventually. So let me start with the brain itself. This is the cross section of the brain. You will see a gray matter outside and a white matter inside. The gray matter constitutes the soma, the cell of the neuron, is what the gray matter is, and the axon, through which these are the connectivity parts that go in. This is the white matter. So the brain is divided into quite a few lobes: frontal lobe, temporal lobe, parietal lobe, occipital lobe, and there are other important structures, which is hypothalamus, amygdala, and hippocampus, that I would like to bring your attention to. So the frontal lobe, which is here, it has got a huge kind of role in personality, decision making. There is an expressive speech center in the frontal lobe. In the parietal lobe, it helps in identifying objects, understanding the spatial relationships, interpreting the pain and touch. Occipital lobe, which is this part, the vision, the tracts from the eye, they go all the way back to the occipital lobe. Temporal lobe is this part on the sides. This is where our memory centers are, the short-term memory. There is perceptive speech centers as well. The hippocampus and amygdala have got huge, again, with a huge role with memory, learning, navigation, perception, which is, again, if there is any problems in these centers, it will be reflected in the clinical presentation. So the next slide, I'm just gonna play a video behind. So just to give you a rough idea, there are about 100 billion neurons, and each of these neurons, they connect to each other through synapses with over 100 trillion synapses. And usually there are tiny chemicals that are released in these synapses, which essentially helps the information to flow from one neuron to the other. So just like these stimuli which is going through, and this is the synapse which I was talking about, the chemicals which help flow the information from one to the other. There are several theories as to why individuals end up having dementia. One is due to the, as you can logically speaking, if you think if the neurotransmitters or the chemicals are decreased, then there is lesser information flowing. So they're suspecting perhaps that is one of the theories. But the hallmark feature of Alzheimer's, you will find abnormal protein deposition called as amyloid, which ends up with amyloid plaques, or these tau proteins which stabilize these microtubules, these tau proteins. If they disintegrate, basically they get clumped and they become neurofibrillary tangles. So this is the hallmark feature of Alzheimer's disease. And there is, if you do a biopsy of the brain, you will find there will be a shrinkage of the brain, especially at the hippocampus where the memory centers are. That leads me to the definition of dementia. It's a progressive disease, and it affects various cognitive and behavioral as domains of the presentation. And this includes loss of memory, language disturbances, reasoning difficulties, personality changes. And because of all this, usually they end up having impaired activities of daily living. So it has huge implication on their functional aspects. It was first described by Professor Alois Alzheimer, who was a neuropsychiatrist in 1906. He noted a 51-year-old lady by name Auguste Ditter. She presented with jealousy, rapid loss of memory, disorientation in her house. She was carrying things from one place to the other and hiding them. And she was having paranoid thoughts as though somebody was trying to kill her, and used to have behavioral problems like screaming and agitation. The common symptoms of dementia, the most commonest one is the memory loss. So you will have an individual presenting with simple, like not able to remember the appointments, or misplacing, placing their personal items somewhere and forgetting about them, the short-term events, meetings, and so on. Difficulty performing tasks. So it could be as simple as using a remote control, or opening the car door, or driving, or working on a microwave. So any one of them, they will have difficulty performing them. Problems with the language. They might not be able to complete sentences. Midway through the sentence, they may struggle to remember what they were talking about. Or they might misplace the words, replace the words with something else. Disorientation to time and place. They might forget where they are, why they went to that place, and they might even, more commonly when we are going through the history, we try to ask about prayers. Are they able to remember, recall what time, which prayer call is it? And sometimes they end up praying 2 times, and so on. Poor or decreased judgment. We have come across people having had difficulty with finances. They have ended up losing, performing quite badly at their businesses, and then losing millions of reals. There are times when the patients have ended up giving the salaries to their maids a few times, and forgotten that they have given before. Problems keeping track of things. So they have issues remembering the events, and they're not able to keep track. And they always rely on somebody to prompt them. Misplacing things, as mentioned earlier, like personal items, including mobile phones, keys, and so on. There is a majority of the times, people with dementia end up having behavioral and psychological symptoms. They end up having anxiety, they have depression, they've got screaming, agitation, aggression. And then there are people who have also presented with history of spatial or visual spatial disturbances. People have ended up having road traffic accidents, either because they have ended up entering into a wrong way, or breaking the traffic signal rules. And people with dementia, because they're not able to keep up with the conversations, with the meetings, with the disorientations, with forgetfulness, they always perform, they underperform at their workplace, so they start to get socially withdrawn, and they try to have low initiatives. So any one of these signs, try to keep an open eye and try to identify and refer immediately. How will you differentiate between a normal aging process with people with dementia? So these were the domains which I just quickly mentioned to you about. So the learning, executive function, language, orientation, visual, perceptual, and mood behavior. So the middle column, it describes person with normal aging. Usually, they're able to retrace the steps of misplaced items. Usually, people with problems with aging, they are able to recall forgotten names or appointments. Although they are slower to react or think, they are able to do, they're able to perform the executive functions. Yes, they are lesser able to do multitasking, especially when they're distracted. However, they are still able to do it. There are sometimes they do have word finding difficulties, and they will have to concentrate harder to keep up with the conversation, but they are able to lead a normal conversation without any difficulty. We are disoriented about day or the week, but usually we end up figuring it out. Sometimes we go to a different room to get something, but then we forget why we're there. But eventually we will be able to recollect. So that's okay. That's normal aging. People with normal aging will have visual changes due to specific organic causes, such as cataract, or that can lead to cloudy or misty vision. And there is, we are wary of work sometimes with family or social obligations. We feel a little bit low or anxious, but usually there is always a compensatory mechanism by which we pull through. So this is normal aging, which is, but people with dementia, it's entirely opposite. They're not able to perform as with a person with normal aging. Especially, I just want to bring to your attention to the visual perceptual skills. They usually have perceptual problems. They misinterpret the visual information, such as the stares, the patterns, or reflections. That leads me to the next slide, which is on different types of dementia. The most commonest types of dementia is Alzheimer's disease, about 60 to 70%. They usually present with memory loss, confusion, difficulty communicating, anxiety, and they'll have abnormal thoughts of paranoia. Somebody is trying to harm them or poison them, and so on. In comparison, vascular dementia, you see about 10% of the cases. With usually the presentation is with impaired judgment, decreased ability to plan. They may have memory problems, and there is usually lack of motivation, and they will be more frailer compared to Alzheimer's because of the multiple comorbidities, especially the vascular risks. In my practice, I see a overlap between Alzheimer's and vascular a lot. I see a lot more of mixed dementia rather than specifically one type. There are lesser common types, such as Lewy body dementia, who usually present with sleep problems, visual hallucinations, gait imbalances, and frequent alertness swings. So they are sleepy at times during the daytime, and then the next minute they are more alert. There are many other types, but the younger people develop frontotemporal dementia with decreased inhibition, apathy with loss of interest or motivation, decreased empathy, repetitive of compulsive behaviors, anxiety, and depression. I'm just going to touch base on diagnosis and management for the next few slides now. The diagnosis, as you can imagine, with any clinical condition, we rely heavily on history, both from the patient, if the patient is able to, and collateral history from the informant. Either it can be a close family member or a caregiver. And then I'll touch base briefly on examination, investigations, and then the common differential diagnoses that we come across. I already went through the symptoms. Usually, dementia is a slow onset condition. You will have a few months history of progressive loss of cognitive symptoms, as discussed earlier. In addition, they may have some psychological and behavioral symptoms such as anxiety, hallucinations, depressions, agitation. Commonly, people with dementia will have sleep disturbances, especially as you may have heard the term sundowning effect. They are more aggressive and agitated as they go during the evening times, and majority of the time the sleep disturbance is there is a reversal of sleep cycle. People with dementia end up being awake all the night and sleepy during the daytime. This has huge implication on the caregiver, especially the caregiver is working, is the bread earner of the family. Don't forget to go through the past medical history and risk factors. I'm going to touch base on the risk factors in a minute. But the common conditions that we ask is about hypertension, stroke, diabetes, renal disorders, and previous history of head injury. Medication history is important, as with any condition in older adults, because some of the medications such as antihistamines, anticholinergics, you might be able to reverse the cognitive decline if you identify and stop them. There are other reasons, the other medications such as antiepileptics, antipsychotics that can affect the cognition as well. To plan, to create a person-centered care and care plan for people with dementia, you need to understand what daily activities of living they are able to perform. So they need to know, you need to know about their banking abilities, driving, using appliances, and so on. The other risk factors, cardiovascular risk factors, smoking and alcohol consumption, you need to identify and address them promptly. We need on the left-hand side, I've just mentioned about the informant history. It's quite important to get that history from the informant. Identify the primary caregiver so that you can start some support process for them. And confirm the onset of the symptoms and the other symptoms in detail. Most importantly, identify the risks that are that the older adult may face. For example, who would be the one who would be giving medications? Whether if the older adult is still driving. If so, then you need to advise them to stop straight away if there is any requirement for modifications at home. This infographic from Alzheimer's International very nicely describes the 12 dementia risk factors. Very rightly, Dr. Nasser was talking about when aspect and why does an adult develop dementia. So so far, these are the 12 risk factors that have been identified. Physical inactivity, sedentary lifestyle puts you at high risk. Smoking, we all know, increases the cardiovascular risk, which is associated with dementia. Excessive alcohol consumption eventually leads to brain atrophy, problems with injuries, with falls, and so on. Air pollution, head injury, infrequent social contact. So those people who have less social interaction are at higher risk of having dementia. Those who are educated only below the less than the undergraduate degree, again, they are at higher risk of having dementia. Obesity, hypertension, diabetes, all of them increase the risk of vascular comorbidities. Depression, in other words, depression is also a risk factor, and at the same time it is a differential diagnosis as pseudo dementia. So I'll come to depression in a minute, but people with depression, they carry a risk of developing dementia if left untreated. And we have strong evidence to suggest that those people who have got hearing impairment, especially the early onset, are at higher risk of developing dementia eventually. So there is a drive towards proactive approach in identifying hearing impairment right from the midlife. Just briefly, I'll touch base on what we do when they come to the clinic. So we go through a physical exam, especially the neurological, to check for any neurological signs. Majority of the times, if there is, as we all grow older, we have comorbidities. We end up finding few signs during the examination. However, in Alzheimer's disease, we may not find any. Mental health assessment is quite important. As I mentioned to you, pseudodementia, which is depression, is a differential diagnosis. So you might literally miss something reversible if we don't pick a depression early on. Then we go on to assess cognition in detail using standardized tools such as Minicog, Montreal Cognitive Assessments, Addenbrook's Cognitive Examination, and we need to be very careful when we are interpreting these scores, because if somebody who has difficulty, learning difficulties or communication difficulties, you'll not be able to perform this. And also, if somebody has got low educational status, you might have a very low score that may skew your diagnosis if you totally rely on these scales. So that's why it's so important that the history taking with informant is very much required for the diagnosis. So then you need a neuropsychologist input to distinguish between mild cognitive impairment. I'm sorry, there is MCI, which is mentioned there, with early dementia or dementia with other cognitive impairment syndromes. As I mentioned earlier, we need to have functional assessment documented right from the start so that you can help make the quality of life better as the disease progresses. Don't forget to identify and address the carer burden there is a standardized tool that you can use, Zareth Burden Interview. Again, the purpose of doing investigations, as I told you earlier, you can diagnose dementia clinically with examination and history. However, investigations will help you rule out any reversible causes or identify other causes. So simple routine blood tests to check for the kidneys, liver, to rule out hypothyroidism, vitamin deficiencies may help you address any reversible causes. ECG is required just to ensure some of the medications that you use for dementia can affect the heart rhythm. It can slow down the heart and it can affect, it can cause the heart to stop. So you need to have a documented evidence. CT MRI will help us rule out any kind of space occupying lesions or previous trauma or bleeding or strokes, and also it will help in looking at the hippocampus to see if there is any atrophy, which is commonly seen in Alzheimer's disease. We don't usually do lumbar puncture and EEG unless it is atypical conditions such as Creutzfeldt-Jakob disease. Again, These are not very common. Usually, you will have some clinical features, and presentations are usually quite early, and rapidly progression is noted. So for a diagnosis, you need to have significant cognitive decline from the previous level. And we have documented evidence of, objective evidence of cognitive domains being affected. This is impairing functionally their activities of daily living. So if you have this, then you can diagnose somebody with dementia, as long as there is no evidence of acute illness or there is no kind of recent decline. It is a kind of gradual onset over a period of months rather than a few days. They may or may not have behavioral disturbance at the time of presentation, depending on at what stage they have presented. That leads me to just briefly touch base on the common differentials. I just want to touch base on the mild cognitive impairment and depression. Again, the same domains that I'm going to go through. So I'm going to talk about mild cognitive impairment first. So usually in mild cognitive impairment, it may one or more cognitive domains may be affected. Like I described earlier, it could be memory, it could be attention, orientation, or it could be language. So any of these domains can be affected, but usually mild. Their activities of daily living is not impaired. They will be fully functional. There will be some of them will still be working at that point. They do notice themselves that they have difficulty solving complex problems, especially if they are subjected to multitasks at the same time. And usually their mood is normal. And then I'll go to the left-hand side column, which is the depression. Usually, again, there will be more than one domain that may be affected, but to a lesser extent. Usually, there will be preoccupation of symptoms, excessive preoccupation of symptoms, and their activities of daily living will not be impaired unless it is very severe. They present with loss of interest or pleasure, loss of appetite, decreased or increased sleep, or loss of energy or concentration. Mood almost always is low and rarely improves with stimulation and support. There may be some suicidal thoughts, and there is usually a guilt or worthlessness in cases, quite severe cases. The other reversible causes of dementia, which I briefly touched base on, as I said earlier, we need to do scans to rule out brain tumors or bleeds. You can do something about them. There is a condition called as normal pressure hydrocephalus. If you catch early, you can try to relieve the pressure by releasing the CSF fluid. That will, and placing a shunt in, that will help maintaining the pressure and preventing the progression of the disease. There are simple vitamins that if you identify they're low and if you replace them, you will see subjective improvement in cognition. And there are some endocrine disorders that are easily treatable. Infections, inflammatory disorders, it's quite important to have an open mind if there is an atypical presentation. And history of alcohol consumption will help you identify early and address it. So I've just divided the management part into general care, non-pharmacological management, pharmacological, and a focus on primary and secondary prevention, and finally concluding the management part with support provided to the caregivers. The management, the general care that we provide for older adults with dementia, ensure we identify the needs of the individual and holistically approach and create a comprehensive care plan that will address all the needs of that individual. We need to have case coordination, ensure that people with dementia do not end up having duplication of services or multiple approach to various specialities. And there is a clear follow-up with a case manager, ensuring all the needs are addressed in a prompt manner. Earlier on in the disease, ensure that we look at the care planning, advanced care planning, about advanced decision to treat or not to treat, about feeding, about resuscitation, involve them in decision making, both if the patient is able to do, or if it is quite advanced, then involve the family in taking the decisions. Again, importance of identifying early is to see whether we need to identify a place of care for them in the future when things get out of control. What I mean by that is if there is total dependence on activities of daily living, and if the caregiver is not able to manage, then you might want to consider options of respite or long-term care. Older adults are already vulnerable. With people with dementia, they are even higher at risk of having, problems with neglect and injuries. So we need to have clear safeguards in place. And finally, assess and manage comorbidities as a single discipline, just so that we ensure further, risks of strokes and other comorbid conditions do not end up causing poor quality of life. I already touched base a little bit on the psychological interventions and ensure that we identify what are the person engagement strategies. Use music, aroma, bright light, animal-assisted therapy, especially multisensory stimulation, has noticed to reduce the behavioral problems or agitation, aggression in people with dementia.
Do try and wrap up as you could, Dr. Khan. Thanks.
Sure. I just have 2 more slides. So for the pharmacological approach, we only have 4 medications that has been authorized to use. Again, you need to remember they do not stop dementia from getting worse. They may delay the progression, but it is inevitable as it is not a cure. So these are the 4 medications: donepezil, galantamine, rivastigmine, and memantine. For behavioral and psychological conditions, I already mentioned you can use antidepressants, antipsychotics, or medications, hypnotics, such as for sleep disturbance, such as trazodone and melatonin. Just a little bit on prevention and prevention aspect. Already Dr. Nasser mentioned about the diet, the physical activity. There is a huge evidence that this will help reduce the risk. And as I mentioned earlier, the vascular risk factors need to be addressed, identified, and need to be addressed. Hearing proactive approach is important. During your midlife, regular meditation to reduce stress and involvement in social activities is very important. For carers, identify the risk of stress, anxiety, depression, and find support services, especially care coordination seems to help a lot for the carers. This is my last slide. What we can do is we can understand the disease better, and we differentiate normal aging from dementia, destigmatize this condition, and try to organize activities and opportunities to socialize, such as majlis for people with problems with memory. That's all I have to say. Thank you so much for listening. I'm sorry if I've gone overboard on time. Thank you so much once again.
Thank you, Dr. Khan. Very, very exciting, very interesting. So as I mentioned earlier, we'll hold off on Q&A till the next presentation. So that was very nice, and looking forward to hearing now from Dr. Brajesh Satyan, So Dr. Brajesh is a postdoctoral research scientist and deputy chair for research in the Geriatrics and Long-Term Care Department at Rumaila Hospital. That's part of the Hamad Medical Corporation here in Qatar. And he has 14 years experience in clinical research and teaching. He worked 10 years as an assistant professor in the community medicine department at Manipal College of Medical Sciences in Nepal before joining HMC. He's also visiting faculty at the Department of Health and Social Sciences at Bournemouth University in the UK and the School of Allied Health, Faculty of Health, Education, Medicine, Social Care, Anglia Ruskin University in the UK. He's also the PhD guide at JJTU University in India. Dr. Satyan is a consultant and chartered statistician at the Royal Statistical Society in the UK, served more than 5 years as chartered scientist in the Science Council of the UK, governing body member of several epidemiological and medical research associations and editor for their journals. He regularly participates as a resource person and organizing committee member, conferences, symposium, workshops, and short courses covering epidemiology, research methodologies, and scientific writings. So he's published quite extensively and been involved in training many MD and PhD students, and clearly is an expert in this domain, of which we're looking forward to hearing his presentation. So Dr. Satyan, I turn it over to you, and we look forward to hearing your presentation. We can see you. I'm not hearing you. Dr. Brajesh, I see your presentation, but I'm not hearing you.
Hello.
There we go.
Yeah, I can switch off my video so the voice will be clear.
Okay, great. Take it away. Thank you.
Yeah, thanks. Thanks, Dr. Lawrence. I am grateful to Hamad bin Khalifa University, this webinar organizers, and Dr. Hanadi ma'am for giving me this opportunity. And today I would like to talk on a roadmap on dementia research in Qatar. Good afternoon, everyone. I have nothing to disclose. Overview of the Geriatric Department research. Under the leadership of Dr. Hanadi Al-Hamad, Geriatric Service is committed to aging-related research and academic activities in line with the goals of Qatar National Health Strategy and World Health Organization's Healthy Aging Program. Our research program aims to develop clinical knowledge in order to optimize and improve the treatment of aged patients in Qatar. This is our team receiving Star of Excellence Award. We have received several awards related to dementia. And our department research activities, we design research studies, proposal and grant writing. Also, we do coordinate with the Medical Research Center, research meetings and journal club, preparation of presentation at international conference, and the final preparation of research findings for publication. That also we do. This is our research areas: risk reduction, diagnostic tool validation, genetics, systematic review, large data collection projects, and clinical trials. The common goals for dementia research are prevent future cases of dementia through increasing knowledge of risk and protective factors, maximize the benefit of people living with dementia and their families when seeking and receiving a diagnosis of dementia, improve quality of life for people affected by dementia by promoting functional capabilities and independence while preventing and treating negative consequences of dementia, enable the dementia workforce to improve practice and skills by increasing evidence to inform changes in practice and culture, optimize the quality and inclusivity of health and social care systems that support people affected by dementia. This is the global goals. And our ongoing dementia research projects are the themes that are dementia risk reduction projects, constipation with cognitive impairment, functional and cognitive impairment prevention through early physical activity, delirium population health inflammatory cohort Qatar, dementia and polypharmacy, validation and adaptation of diagnostic tools. And the last one is biomarkers of neurodegeneration in the eye and brain and blood-based transcriptomics, proteomics, and metabolomics to predict the development of dementia. Now, we also have Dementia Registry. Data on dementia and dementia care remains extremely limited, can hamper efforts to improve quality of care and outcomes. Qatar is among the few countries which have developed a dedicated process to collect, store, and share data on dementia. The lead PA for this registry is Dr. Hanadi Al-Hamad. And this was our dementia registry journey. We have submitted the proposal to IRGC 5 on 2018, and we got the MRC approval in July 2020, and HICT approval was in 2021, and the final MRC approval was there in August 2021. And the dementia registry objectives are to collect epidemiological data on prevalence, incidence, and risk factors of dementia, to develop and measure effectiveness of interventions to reduce the risk and incidence of dementia, its treatment and management, to provide data on the natural history of dementia, determinants of progression and their implication for clinical management, to monitor the quality of dementia care, to evaluate the diagnostic criteria for dementia, to standardize and validate screening and assessment tools in Qatar, to develop a registry in order to support clinical and decision-making process in framing healthcare policies through epidemiological data, to enhance the care and support for dementia with evidence-based policy, and to support research to causes and risk factors for dementia. And the last objective is to provide the information on utilization and cost of health and aged care services and care support, and to inform planning and development of dementia services. Now, we are planning for future research collaborations. Future research plans in collaboration with other national and international institutions are exposure to air pollution and dementia, developing an artificial intelligence-based lifestyle intervention for prevention of dementia, implementation and impact of dementia-friendly community initiatives, identification of digital biomarkers for Alzheimer's disease, reducing hospital readmission in Alzheimer's disease and related dementia, the development of community education for family caregivers, and frequency and determinants of vascular cognitive impairment post-stroke, association of cognitive impairment and education, promoting brain health, development of patients' education resources, burdensome end-of-life treatments in older adults with advanced dementia, the longitudinal linkage between insulin resistance and Alzheimer's disease, optimizing prediction of clinical progression in MCA population, comparing novel biomarkers in Alzheimer's and Parkinson's disease, feasibility identification of those who may benefit from palliative care, alcohol use patterns and dementia, role of traumatic brain injury in Alzheimer's disease and related dementias, age-related hearing loss and neutral correlates of visual short-term memory, characterizing dementia caregiver stress and its far-reaching impacts, awareness and knowledge of dementia among speech and language therapies, blood biomarkers for discriminating amongst neurodegenerative diseases, end-of-life care planning intervention. We used to organize several international conferences and workshops under the leadership of Dr. Hanadi Al-Hamad. And we have also the international short courses for research methodology and scientific writing. We are also planning for dementia-related research methodology courses. These are the few courses we used to conduct yearly. And we are having several international collaboration under the leadership of Dr. Hanadi Al-Hamad. So that the international collaborations are with the Bournemouth University, University of Huddersfield, UCL, ARU, and University de Nevada. And we have inter-institutional collaborations also in Qatar. These are our collaborators for research and education. For any additional information and future collaborations, please contact Dr. Hanadi Al-Hamad, Qatar National Health Strategy Lead and for healthy aging, and chairperson for Geriatrics and Long-Term Care Department, Hamad Medical Corporation. Thank you so much.
Thank you, Dr. Brajesh. Very nice. Sounds like you have many things ongoing, which is fantastic with in Qatar, the region, and for everybody in the world. So we had nice presentations from our three panelists, and we've had a few questions have come up throughout the talk, and so I can relay those on to the speakers. Maybe for those speakers who are comfortable, you could turn your videos on and we can have a little discussion session here. So there's quite a few questions, and I'll direct this to the panelists who care to answer on and sort of vitamin deficiencies and association with dementia. Some particularly asked about vitamin D, calcium, phosphorus as risk factors, and I'm scrolling, and I think there were some other I think selenium came up from one of the questioners. I'm just kind of combining a few different questions, but maybe I'll direct that to Dr. Khan. Anything you want to add in on the association of dementia with some of these deficiencies in vitamins, minerals?
Thank you so much. When they present to our memory clinic, we do check vitamin B12, folate, and vitamin D. And if there is any deficiencies, we usually replace immediately. There are many others, there is no clear evidence, like for example, for vitamin E, vitamin B supplements, for omega-3, ginseng, ginkgo biloba. So all of these, there is no supportive evidence to recommend to either as a preventive or as a treatment part. There is no evidence to support, in the management plan.
Okay, thank you. And the other panelists want to add on to that? I guess there's a lot of people thinking some supplements might prevent or at least mitigate problems. Dr. Nasser, or anything to add on that?
Not really, not much to add, but sometimes we have to be many of these things that vitamins, other things, either concerns or use, in terms of supplements. There is no specificity when it comes to Alzheimer's disease. They're really just good for overall, health and well-being and the aging process. So really, a lot of times when we speak about things, either deficiencies or supplements, nothing to say that's really with specificity for Alzheimer's disease. I was really
excited to hear from Dr. Satyan about the registry. I think this is really important, and there were a couple of questions that maybe they came up even before you presented, but really along those lines about looking at family relationships. And myself as sort of a molecular geneticist, I'd like to know a little bit more about your thoughts on the genetic predisposition of AD and other dementias. Dr. Brajesh, you have any comments on this?
Is it related to registry?
Well, I think the registry was sort of getting at a couple of questions which were asking really about, familial, heredity of AD. You know, what do we know about that? Maybe we don't have enough information, but maybe the registry will help improve that kind of information. So maybe you want to say a little bit more about the you know, the familial relationships that you see with dementia.
Yeah, from the registry, we can study these all variables, and once we will get the variables and information, we can do the research related to it, and we can find out the relationship.
Maybe the other panelists, any comment on, you know, hereditary nature of dementia?
Sure, I can make a few comments on that. I mean, we have to understand that 95% of the cases of Alzheimer's disease do not seem to have a very clear, you know, hereditary pattern. They seem to be, you know, sporadic in nature and random, even though there have been some really, a lot of, you know, genome-wide association studies have identified, you know, some gene here or the other, but no clear really risk there, except, you know, for a small subset of those which have ApoE, ApoE4 relationship to that. And that's really a subset. So it's a much, maybe 20, you know, a subset of the 20% of the 95%, if you wish. So there isn't any clear, you know, genetic, you know, or remarkable genetic association for the majority of cases of Alzheimer's disease. That's the 95%. The 5% or less, you know, depending on who you talk to, they have a very clear, you know, genetic, you know, connection, and they have early onset. So they're very, you know, they occur much earlier in age, much earlier than the 65 or older for the late onset. And in those cases, you know, the connections come to the amyloid, you know, hypothesis of Alzheimer's related to amyloid processing, amyloid plaque development, or genes associated with amyloid and the amyloid precursor protein and so on. As well as, you know, when we talk about frontotemporal dementia, there is some connection to tau, you know, and genetic predisposition related to tau. So the small, you know, percentage of patients with dementia, whether those with Alzheimer's disease or the frontotemporal dementia, have some clear genetic inheritance pattern.
Thank you, Dr. Nasser. Maybe I'll ask this question verbatim. I'm not quite sure I understand it, but I think the panelists might. It says, are there any patterns in the distribution of occurrence of dementia across the world? And if such a study has been done, where does Qatar fall in this regard? So patterns of distribution of dementia across the world? Anybody want to respond to that?
So I can just briefly touch base on this recent study, which is ongoing. So we just wanted, because we didn't have any data about what is the prevalence or incidence in Qatar. In 2017, Dr. Hanadi started to collaborate with Primary Healthcare Corporation and try to identify, get people into the study to understand what are the different types of dementia that we come across, at what stage are people accessing healthcare and so on. Unfortunately, this study, you know, we could not get a complete picture because of many reasons. But usually the presentations are of mixed dementia, presenting quite late in the disease. This was going back 3 or 4 years' time. But since then, what's happened is there is a huge, after continual efforts of these awareness campaigns, we have noticed, you know, a huge shift now. Now we have, you know, seeing people accessing the healthcare system even quite early on, because we've got quite a few memory. Dr. Hanadi has established memory services in few healthcare centers, and also there is a direct telephone helpline called as Raha, which has enabled them to access the you know, the memory services quite early and get into the system. So to answer to your question, we don't have any objective evidence at the moment, but I think the studies, what's the space, we will soon have more information on that with the types of dementia, the pattern, but with the huge cardiovascular burden in the Middle East and in Qatar, we do see a mixed type of dementia a lot compared to the others.
There was a question asking about aducanumab therapy. I hope I said that right. Aducanumab, monoclonal antibody. The question was a couple of things. One, is it available in Qatar, and is it effective?
Okay, so it's not available in Qatar yet. Is it effective? As far as I see, the initial phase 3 studies, it has shown some benefit for the milder ones. I'm not sure. I don't think it did for the moderate to severe.
Is this the Biogen? Is this the Biogen?
Yeah, this is the Biogen,
Okay.
Larry. Yes.
Sorry, I didn't know the name yet. Okay.
Yeah.
So maybe just for the audience, you could recap one of you guys, because I know it's controversial that this is approved in the U.S. The panel actually didn't approve it, but the FDA did approve it. So maybe you can comment on the controversy. Maybe Dr. Nasser, I'll call on you to tell us a little bit about that.
I can say something, but maybe Dr. Khan can shed some light, and I can add my thoughts about this as well.
Yeah, no, please go ahead. I think that's all I had to. I just wanted to say.
Okay, yeah. So it has been, very controversial. We've seen, this monoclonal antibody, treatment presented at conferences for Alzheimer's 2 or 3 years ago, and then when it got to phase 3, and then it was declared as really working and promising, and then they withdrew, they retracted, Biogen, their data, and said, they had to, reassess it and look at it again. Then it came back, much later from that, where I think they looked at a subset of their data, or the way they were doing their, determination, and found that there is some efficacy. It's a very controversial, as Dr. Stanton has mentioned. I mean, the key and the maybe the most important development when it comes to those of us doing, drug discovery in Alzheimer's disease, and a lot of the efforts and the billions spent, is I think the FDA approved it, for lowering the biomarker, Dr. Stanton. So this is the first time they're really approving a drug for its ability to lower the amyloid, burden, and not necessarily on clinical, outcomes. And so that was sufficient enough to lead, to its approval. And so this is still controversial, because the connection, between amyloid and Alzheimer's disease is still, although it's one of the hallmarks, whether is it the responsible for the dementia, tau seems to be more, involved in actual development of dementia, but amyloid may build up much earlier, and there's a lot of things related to that. But it might be beneficial. So still, I think the jury is still out there, but it's still controversial.
Yeah, thanks for commenting on it, because I mean, those of us who are in sort of the biomarker discovery area, really pay attention to these things, because it's very hard to use clinical symptomatology as a readout, and so something more, hardcore, or a biomarker, molecular, quantitative biomarker be valuable, but that was sort of the controversy on this: is the biomarker truly reflective of the disease? And this is not just a problem for AD and other dementias, but other things like autism. It's very hard to show these other symptom differences. So thanks for your comments on that. We do have a few more questions I want to get to, so I don't want to stay on that topic. But maybe there was one question was asking about the relation between autoinflammatory disease and Alzheimer's. I think Dr. Khan, maybe you touched briefly on that. Anything else you'd like to add?
So the autoimmune, so we do come across this atypical presentations, wherein on further investigations we we find autoimmune limbic encephalitis and so on. Usually they respond, if you catch early with immunosuppression, they respond if you manage to diagnose early. But if there is no it's not directly causing Alzheimer's, but essentially if you leave it untreated, essentially they end up causing scarring and atrophy and lead to problems with cognitive impairment secondary to that. So not as a cause for Alzheimer's, but if I don't know if Dr. Nasser has anything to add to that.
Not much on my side, but for a very long time, we've been ignoring the role of inflammation in the pathogenesis of Alzheimer's disease. And there've been a lot of retrospective studies that did not show the efficacy of NSAIDs and things of that sort, but prospective studies seem to show promise. These days, I think it is coming into the picture that inflammation may play a role, in AD, and it's not just about the amyloid, but the, inflammation and the inflammatory process. Eventually, when we come for the most effective treatment, it's going to be a cocktail drug, that can do a number of things, deal with the pathological hallmarks, the burdens of the plaques, and the tangles, and the inflammation and other associated events that occur there. But now there's a huge, attention back into the role of inflammation, and there are those who believe inflammation is the key to the pathogenesis of Alzheimer's disease.
Thank you, Dr. Nasser. Maybe I'll just wrap up with quite a few questions. I'm not going to read any one in particular, but thanks for the guests for raising this. So, I think there's a lot of people who are on the caregiving side, and I know Dr. Khan, you touched on it, but maybe you could say a little bit more about, providing care and the challenges of the families who are, involved in dealing with their loved ones with dementia. So use this as a kind of the wrap up discussion, if you will.
Sure. Thank you. Just briefly, I think, again, Dr. Hanadi Al-Hamad identified the huge burden dementia causes to the social services, the health sector, and the caregivers, the families, the community. So she very rightly, she worked really hard, and alhamdulillah, she managed to get the Qatar's National Dementia Plan established in 2018, and subsequent year she got the National Dementia Guidelines, and since then there has been more of person-centered care approach with carers groups. There is a spokesperson from the carer who is actually representing people with dementia in the ministry. So there has been a huge work on trying to optimize the care support. So what is available? So there is case coordination, clearly. So there is people with dementia got clear, there is a coordinator who ensures that, there is easy accessibility for people with dementia to speak to the physicians. There is community services with home health care. They provide support for any acute, deteriorations or any problems with, environmental safety and so on. There is, if people with dementia, if the carers would like to have a little bit of time off as a respite, there is access provided for them to have in the long-term care for a short period of time. And of course, if they're not able to look after, we try to facilitate their admissions into the long-term care. For people with huge behavioral and psychological symptoms, there is outreach services that is available, wherein the old age psychiatrist goes into their homes and assesses people and tries to address any kind of symptoms to help mitigate or minimize as much as they can. But most importantly, majority of the times it's about carer education, really, to find ways by which non-pharmacological techniques like distraction techniques and so on is used, and also understanding the people with dementia. So what were their previous behavior like, personality, what were their likes and dislikes, and try to approach it that way rather than use medications to address them. There is, of course, there has been a significant improvement since last 3 to 4 years of the support services for the carer, but I'm pretty sure there is still I'm sure there is still a little bit more for us to do for them, inshallah.
Yeah, thank you for those words, Dr. Khan, because I think that's it's clear from the presenters today that we're making progress. There's more to be done, but it's nice that we're on the right track. So I think given that this is Alzheimer's Awareness Month, we really appreciate your dedication to this task, and I appreciate the people tuning in. We had very good attendance to this, so I think your words are well taken, all three panelists. So once again, I'm going to just take this moment on behalf of all the attendees to thank Dr. Brijesh Satyan and Dr. Shafi Khan from Hamad Medical Corporation and Dr. Nasser Zawiya from Qatar Biomedical Research Institute for taking the time not only to work on this important diseases, but also to share with us their thoughts and expertise. So thank you all for participating, and have a good day.